Good afternoon and welcome to Cannabis Legalization in New England, using data to understand regional context and consumption patterns. So we're going to start with some housekeeping things here to kick us off. So the New England Prevention Technology Transfer Center, the New England PTTC, is supported by SAMHSA and the U.S. Department of Health and Human Services by a financial assistance award. However, the contents of today's presentation and the authors and the presenters don't necessarily represent the official views nor endorsement by SAMHSA, HHS, or the U.S. government. We also believe that affirming language inspires hope and that language matters and words have power. So we're going to be doing our very best to use person-first language today. Now, thank you again for joining us, and let's do some introductions. So my name is Kim Magoon. I work for Public Consulting Group's Maine office, and I specialize in child welfare and substance use prevention evaluation. And while I worked in various projects all across the country, I am currently the evaluation lead for the New England Prevention Technology Transfer Center. And I'm joined today by my colleagues, Tim Diomede and Megan Hawks. So I'll let them introduce themselves.
Hey, my name's Tim Diomede. I am a evaluation analyst with PCG, but a lot of you might know me as the coordinator of the State Epidemiological Outcomes Work Group for the state of Maine. I've done that for a while now, and I serve as an epidemiologist in that role as well. So I'm happy to be here, and we'll be sharing some great data with you guys today. So I'll pass it to my colleague, Megan.
Great, thanks, Tim. My name is Megan Hawks. I'm a program manager at Public Consulting Group. I have a decade of experience working in public health on a variety of issues at the state and local level. I serve as an evaluator, consultant, and manager for projects promoting population-level health and mental health, substance use prevention, treatment, and recovery, and data sharing projects, as well as data analysis and dashboard creation.
Okay. So what are we going to talk about today? So we all know there's a ton of information out there about cannabis, right? It's a very hot topic. Several states are moving to legalize adult use. However, the fact that it's still a Schedule I drug and still federally illegal really creates this landscape and backdrop. It doesn't always make it easy to access data or for transparent data sharing. And we know that for preventionists, context matters, right? So our goal today is really twofold. We want to dig into some of those contributing factors to see how they're influencing use and consequences for use in New England. And then we also want to talk about how to find some of this data so that you, as state leaders and preventionists in the field, can really take and use this data as an ongoing basis. So here's our roadmap for today. We're going to look at some contributing factors. We're going to briefly go over some history of legalization, some national and current state laws. We'll talk about medical and adult use retail and sales. We'll look at some early use and perceptions of harm. And then we're going to move into talking about consumption data for New England states and what that kind of looks like. And then followed by the consequences and impact of that use. And then we're going to sum up today about how we foresee using data to enhance prevention messaging. So let's talk about some contributing factors. Although you're going to see that states, governing bodies, research, some data sources in our presentation are going to use the terms interchangeably of marijuana and cannabis, we know there's a difference. And according to NIH, cannabis actually refers to all the products that are derived from the plant Cannabis sativa, whereas marijuana refers to only those products that have substantial amounts of THC. So that's a bit of a disclaimer up front. We acknowledge, we appreciate that there's technically a difference, but the sources that you're going to see today are going to use those terms interchangeably. So let's get into it. Cannabis has really been cultivated in the United States since the 1600s. It only became federally illegal when the Controlled Substances Act was passed in 1970. Oregon was the first state to decriminalize cannabis in 1973, and then California was the first to legalize medical use in 1996. Subsequently, other states have begun to legalize medical use, and in 2012, Washington and Colorado became the first to legalize adult use. Currently, there's 36 states and Washington, D.C. that have legalized adult use cannabis, or that legalized medical use, and 18 states that have legalized adult use cannabis. New Hampshire was actually the most recent state to legalize possession of adult use, but they haven't legalized the sale. So there's a little bit of a difference there. But it's important to recognize that this legalization debate is a relatively newer phenomena, right? It's starting in 1970, and it varies a lot across the country. So here we can see from this map that the West Coast and the Northeast are generally a little more liberal in their legalization of medical and adult use cannabis, whereas the Midwest and the South are a little more conservative, with only decriminalization or some approving medical use. But what about New England in particular, this dark blue and black areas at the top there? Well, this data comes from the National Conference of State Legislatures and some individual state websites. We know that all 6 New England states have legalized medical use cannabis. Maine was the first in 1999, and New Hampshire was the most recent in 2013. 4 New England states have also legalized adult use, but only 2 of them, Maine and Massachusetts, have active retail markets at the moment. The other 2 states, Connecticut and Vermont, have delayed their implementation. And next, we're going to talk about some governing bodies for cannabis in New England, because these all look very different. There's no 2 states that oversee cannabis programming in the same way, and they don't use the same language to describe it. So you can see here this quick listing of governing bodies that we're going to talk more about, but Connecticut is overseen by the Consumer Protection Department, whereas Maine is under Administrative and Financial Services, and Rhode Island is under Department of Health, like New Hampshire. They're all very different setups, and we'll take a look here. So in Connecticut, the medical marijuana program is actually headed by a board of physicians, and that operates under the Department of Consumer Protection and comprises the commissioner and the department, commissioner of that department and 8 additional members. So the Drug Control Division also oversees licensing for pharmacies, pharmacists, controlled substance providers, labs, manufacturers, wholesalers, and then medical marijuana is also tacked underneath that. Maine has a different model. The Office of Marijuana Policy, OMP, still operates under the state legislature, like Connecticut, but under the Department of Administrative and Financial Services, and in partnership with the Maine Advisory Commission. So the state of Maine also took a different approach in how they were setting up the OMP, and they actually utilized a marijuana work group with a wide variety of stakeholders. They're one of the only setups like this in New England. Their stakeholders included registered caregivers, dispensary representatives, marijuana testing and product manufacturer representatives, medical cannabis patients, and representatives from the municipalities across Maine, as well as healthcare professionals. So they took a broader stance in trying to set up their Office of Marijuana Policy. In Massachusetts, they use a different setup, of course. They use a 25-member Cannabis Control Commission that's made up of appointees from the governor, treasurer, and receiver general, and attorney general. And these members, and there's some members there as well with specific knowledge and expertise relevant to the board's mission. But they're charged with offering recommendations back to those governing bodies, really regarding the regulation and taxation. In New Hampshire, the legislature has placed the responsibility for administering the Therapeutic cannabis program within the Department of Health and Human Services. And they're responsible for maintaining the program's registry of patients, issuing the certification cards, licensing of retailers and growers and manufacturers. And so you can see this is yet a different model. Rhode Island has another setup for their medical marijuana program. They're housed under the Department of Health, and the Center for Professional Boards and Licensing. It really should also be noted that the Rhode Island Prevention Advisory Council, our committee also, under the Governor's Council, also helps the governor and legislature on a variety of prevention issues, including cannabis. So this medical marijuana program is actually not solely influenced by the Center for Boards and Licensing. They do get help from that Prevention Advisory Council as well. And Vermont has a governance model that falls under the General Assembly. Their Cannabis Control Board, or CCB, was appointed with an advisory committee of 14 members, in addition to the executive director and admin assistant and general counsel. And together they report to the Office of the Attorney General and Department of Health, who promulgates the rules for cannabis programs, administering state licensure, administering state medical cannabis program, and actually submitting an annual budget to the governor. So as you can see, the governance models for New England states are all very different in how they're organized, under which part of the government they operate, who they include for stakeholders, and even the terminology they use, whether we're talking about medical or therapeutic or cannabis or marijuana. They're all very different. And because states differ in their legislation and their governance so much, that also means that access and availability look very different for each state. So states that have adult use laws require adults to be 21 or older to possess. So Connecticut, Maine, Massachusetts, Vermont. But in the states that only have those medical laws, adults only have to be 18 or older to possess. And the amount that a person can possess also varies pretty widely, from 3/4 of an ounce in New Hampshire to 2.5 ounces in Maine. So what does that actually mean? Well, we know that there's many ways in which cannabis can be sold: flower, caps, concentrates, edibles, joints. Here's a picture from the Reno Gazette Journal comparing 1 ounce of flower cannabis to a pair of sunglasses and a lighter to put that in perspective. But again, what does this mean? I mean, how much of a dosage is this really? Well, for comparison's sake, we'll use a joint as a metric, since that's probably one of the most common forms, and we can make some comparisons to cigarettes, which I feel people were pretty familiar with, right? So joints are usually rolled and sold in gram increments, in quarter, half, and 1 gram. There's about 28 1/3 grams per ounce. So depending on how big or small each one is rolled, there could be anywhere from 28 to 112 joints in an ounce. So what does that really mean by state? Well, that means that 3/4 of an ounce in New Hampshire is somewhere between 20 and 85 joints. And for Maine, that 2.5 ounce is somewhere between 70 and 285. So really, to put this into further perspective, we think about cigarettes that usually come in a pack of 20, and there's 10 packs to a carton, so 200 cigarettes. So that 2.5 ounces of Maine that's legal in Maine could really mean something like a carton and a half of smokes. Of course, we know that the more that you have of something, the more potential for diversion. And it's not like retailers are hard to find. While state websites generally have very limited data on where their licensed retailers are located for medical and adult use stores, there are places like weedmaps.com that offer all of that information. The site offers filters for license type, adult or medical, location, delivery, online ordering, if they have a storefront, if they have doctors on site that prescribe you a card. And unlike tobacco and alcohol websites, there's no age requirement for this site, and there's no real protection of any kind to prevent youth usage. So the possibility of youth usage for these kind of websites is pretty high. But it's also important to point out that this data can also be used for good, right? Because this site provides maps and information regarding dispensary licenses and details about the products and delivery methods, preventionists can use this information to target messaging to specific areas and communities that might be at higher risk for availability and potential diversion. But what else influences consumption? Well, the dollar, of course, cost. While the average price per ounce is usually less for medical than adult use cannabis in these states that have legalized both, the cost of the medical card or prescription card can influence who participates in that program, right? So this is actually a map from NBC News, and they've sourced from individual state health departments and medical programs to show that there's a really wide variety of the cost of medical marijuana cards. So some states, like Maine, might waive the fee entirely, whereas other states like Oregon can charge you up to $150 or more annually for this card. And in that case, you begin to think about how cost becomes part of the problem for people who are actually trying to legally access medical cannabis. For $150 for a low-income family, that can be very cost prohibitive. So there's something to keep in mind as we continue to talk about medical versus adult use, access, and retail. But let's explore the medical cannabis certifications a little more first. So for New England, these are physician-prescribed certifications, and they usually cost between $30 to $50 depending on the state. In Maine, you can see that the number of medical certificates issued over the last 3 years has increased exponentially to about 105,000 certificates in 2021, and it's only predicted to go up for 2022. We can also see that states like New Hampshire and Rhode Island have also increased their numbers of medical certifications that they're issuing year over year as well. Massachusetts, as a state, doesn't provide their certification numbers, but there are some estimates out there that suggest that the number of certifications has increased from about 65,000 in 2019 to over 100,000, just like Maine in 2021. And as we've seen, cannabis governance varies widely between states. So this means that the number of allowable dispensaries also varies between states. And it's a wide variation. We have places like New Hampshire, Rhode Island, Maine that have 7, 8 dispensaries. And then you have Massachusetts that has 86 registered dispensaries. So there's a wide discrepancy in the availability. And together, this information impacts medical sales, right? So despite that number of limited dispensaries in some of these states, the increase in medical cannabis certifications has undoubtedly increased medical cannabis sales exponentially in those last 3 years. Here again is a good example of some creative data sourcing. So to put things into perspective, Massachusetts, Maine, and Rhode Island all list their revenue information on their state websites. Data weren't available on state websites for Connecticut, New Hampshire, and Vermont. So these are actually projected revenues from Statista. And Statista is actually a free data website that collects and aggregates data from multiple public and private sectors to reach this predicted information for a wide and they do it for a wide variety of industries. So it's not just because something is not on the state website doesn't mean it can't necessarily be found. You might just need to be a little more creative in how you find the information. And next, we're going to talk about some adult use retailers. So again, Maine and Massachusetts are the only states with active retail markets, so we want to highlight them. And while Maine's market is really only started in 2021, the end of 2020, but really got going in 2021, we can see that they already are reporting more than 70 licenses for adult use retailer. And Massachusetts doubled the number of licenses that they issued for retailers between 2020 and 2021, from 95 to 191 licensees for adult use retailers. And of course, again, we know that cost is a factor in how much people use. And that varies widely by states as well. Cost as a metric is it's a little bit harder to find because cannabis is still federally legal and states are continuing to walk this fine line with how transparent they want to be about their data. But Maine and Massachusetts actually published their adult use pricing online on their state websites. And the other 4 states, since it's still illegal and they don't have active markets, this information actually comes from priceofweed.com, which is actually a crowdsourced reference platform where people who have bought marijuana more recently can input how much they bought and the quality, and then this website aggregates all of those responses into a number. So each of these states had over 1,000 people reporting data points, and so these numbers are probably pretty consistent for those with over 1,000 each. But knowing that context of the cost of cannabis can really further give you context of use and who's using and where they're sourcing from. We also know that prices are declining. So for Maine and Massachusetts, who are listing their price per ounce or gram on their state website, we're observing declining prices over time. And similar trends were actually seen 7 years ago when Oregon and Colorado started to see that as the amount of product increases and the people are growing more of their own product, the cost per ounce in grams decreases. So here we see some fluctuation in Massachusetts in November, but in general, the decline is that both states are declining. However, this decline in price doesn't seem to have impacted profits very much for Maine or Massachusetts. And in fact, they're both seeing big increases. We just saw a moment ago that the medical sales have continued to increase across New England. Despite Maine's legalization of adult use in retail, we can still see that the medical sales for Maine outnumber the adult use retail sales about 3 to 1. It was about 300 million in 2021 for medical, and for adult, it was only about 82. In prevention, I think that there's some thought that when adult use is legalized in the state, that there would be a tendency for the medical retail to decrease, right? So people wouldn't have to go through a physician card. They could just go and purchase whatever they want legally. It would remove that extra barrier. But we can see here that hasn't really been the case for Maine. Both medical and adult use are increasing. And this probably has to do with a few things, but the cost of the medical certification card and tax rates for the product are almost assuredly big influences. So tax rates between medical and adult use cannabis often vary pretty widely between states, and we'll see that next. So several states don't have sales tax for medical use cannabis. And though Maine and Massachusetts are the only states with active adult use markets, Connecticut and Vermont have publicized their tax plans. So this is what they're aiming for. A lot of times medical cannabis is a lot cheaper, despite the cost of the medical card. And so to put this into perspective, we're talking about, 0 to 20% taxes for cannabis, and a pack of cigarettes is somewhere between 40 and 50% tax per pack. So the tax rates vary widely between the same products in the states and between different substance use products that have been legalized. But how are states using all of this money, right? So legislation dictating how these funds are spent also seems to vary widely between New England states. We're seeing a theme, right? Some states are very prescriptive about what percentages and tasks the funds need to go to, while other states are really vague, and not all of them require that money to be spent on prevention, treatment, or recovery. You can see in Connecticut that they break this out by specific percentages and which accounts they need to go to and what they're supposed to fund, whereas Vermont has a very vague plan that just says grant programs to start or expand after school or summer learning programs. It doesn't really tell you a whole lot of content about that. Before I pass this off, I do want to briefly switch gears a little bit and talk about some traditional contributing factors as we get into consumption patterns. And so we know that early initiation of substance is a big predictor for adult use. And so for New England, we can see that despite the medical legalization, the increased access and availability, even with all of that, the trend for earlier initiation of marijuana, that is before the age of 13, has gone down. Now, this hasn't been updated for 2021 yet, so we'll expect to see some new data probably in the next few months here. But from 2015 to 2019, we can observe consistent decreases all across the New England region and across the U.S. as well for people, for youth that are trying marijuana for the first time before age 13. We can also pull this data apart a little bit. And so here's the 2019 Youth Risk Behavior Survey and broken out a little more by some demographics. So we can see that males are more likely than females to have tried earlier. People who identify as anything other than heterosexual are more likely to have tried earlier. And people who identify as Black, African American, Native American, Alaska Native, or as multiple races are also more likely to experience early use. And then further, we know that the perception of harm is a risk factor for use, right? And a contributing factor. So 2018-19 National Survey on Drug Use and Health, NISDA, says that the national average for people perceiving great risk for smoking marijuana at least once a month is around 24%. But we can see from this map that New England has markedly lower rates here. They're all in this dark blue, which is somewhere between 15 and 17%. And we can break this apart a little further to see that 18 to 25-year-olds also have the lowest perception of risk, around 12 or 13% in terms of age groups. However, all age groups have decreased their perception of risk over time. And on top of all of this, we have to acknowledge that cannabis tourism is a growing venture, and websites like visitnewengland.com, which have a lot of great information, also have entire sections of their website dedicated to attracting cannabis tourists with information about the laws in each state, where to buy it, and suggested places to use. This information is all out there, and it's all relevant to the context in which preventionists understand cannabis use and have to design prevention campaigns. So now I'll pass it off to Tim, who's going to talk about cannabis use and consumption patterns.
Thank you, Kim. There's a lot of great data around the contextual factors and contributing factors, especially like the stuff around taxes by New England states, and surprised to see that Maine has some of the lower taxes there for adult use. So we're going to step back a little bit and look at prevalence data. Yes, you're going to get the slides, I believe. And so for consumption data, prevalence data, we use those terms interchangeable. We rely heavily on survey data, so self-reported data that comes from either National Survey Drug Use and Health, NISDA, or YRBSS, which is the Youth Risk Behavior Surveillance tool. And sometimes we look at briefest data as well. Here, we're looking at NISDA and its past year use by drug type among those who are 12 and older. This is national data. And we can see that after alcohol, marijuana is the most used psychotropic drug in the U.S. So about 1 in 5 Americans 12 and older reported using in the past year for marijuana. And that counts for about 45 million citizens. And we can see that it's been relatively increasing aggressively over the past couple of years when we compare it to cocaine, methamphetamine, heroin that have already been relatively stable over the past couple of years. Next slide, please. And this indicator, we're stepping back a little bit more, and we're looking at the annual rate of first-time use. So, for instance, in 2018, 2019, 8.4% of young adults use marijuana for the first time. And those that are 12 and older, 2.3% of Americans used marijuana for the first time in the latest period of data, 2018-19, that we have. And that accounts for about 3.4 million citizens. So we can see that people are using for the first time is mostly prevalent in the young adults. And we can see that trending data is trending slightly upwards over the past couple of years here. Next slide, please. And this is a map of that same data, so we can see that as we saw in that early initiation data that Kim showed, we can see that there are higher rates in the Northeast as well as the West Coast. So Northeast, it ranges from 3% to 4.19%. Hard time hearing Tim. Okay. I did not say anything about suicide, but I will try my best to speak up. Okay, so here we have past month marijuana use by age, and this comes from NISDA as well. And probably not a big surprise to anybody here that's listening. Rates are highest among our young adults, with about 1 in 4 18 to 25-year-olds reporting using marijuana in the past month. And again, rates have been increasing among that population, as well as those are 12 and older. You can see that went from 9% to 11% from 2016 to 2019. Next slide, please. And if we want to look at like an infographic here, we can see that past year use among young adults nationwide. About 1 in 3 young adults have reported using in the past year. So that accounts for a little over 12 million 18 to 25-year-olds using at least once in the past year. And here we're looking at just the New England states compared to the U.S. average. That thin blue line I just put there recently to just make sure that you guys can see how we compare to the U.S. You know, the major takeaway here is that New England states, regardless of which state you live in, have higher rates of young adult use of marijuana. And we can see that in states like Vermont, it's actually looks like it's 16 points higher than the U.S. average. Connecticut has one of the lower rates in New England. So there's a little bit of variation between these states, and in it, of course, there can be some parallels drawn to some of the regulations and when it comes to adult use and recreational use and medical use. Next slide, please. And again, here's just the same data, but we can see how we compare to the rest of the U.S. And again, we can see that there are some higher rates in the northeast part of the country as well as the West Coast. Okay, so looking at high school data with YRBSS, here we have students who reported using at least once in the past 30 days. So nationally, about 1 in 5 students used in the past month, 22%. And we can see for the most part, New England states were either on par or above average, with Massachusetts, Vermont, and New Hampshire leading the pack. And rates have been relatively stable in most New England states, but we can see that there's been increases in New Hampshire, steady increase in New Hampshire as well as Vermont over the past couple of years here. And as Kim alluded to, we are highly anticipating that new set of data from YRBSS. And same indicator here, but we're looking at it broken down by a few demographics. Not a ton of variation when it comes to gender. Where we are seeing the variation is within the sexual minority population, those that identify as gay, lesbian, or bisexual. About a third reported using marijuana in the past month. And when we look at race and ethnicity data, we can see that rates are higher among the Alaskan Indian, Alaskan Native population, as well as those who identified with multiple races. Laurie asked, what's the second S? Well, there isn't a second S. I added one because Briefus has a second S. My apologies for that mistake. So past month frequency of use by gender. So this is an interesting, the next couple slides are interesting because we're looking at frequency of use, distribution, as well as demographics. And so this one looks at frequency of use by gender. And so if we're looking at any use, we can see that there is a slight difference between male and female, 13% versus 10%. What I think is more interesting is when we look at the 21 or more days distribution there, more of a habitual use, I would define that as. And we can see that males are more likely to habitually use than those that are female. And the next slide, this slide looks at very similar data. It's looking at race and ethnicity. And the data is kind of all over the place here, but when we do look at that habitual cohort again, we can see that of those that used any in the past month that were heterosexual, 4 out of 10 reported using 21 more days out of the month. And you can see that rates are also higher among those that identify as Black or African American, and those who identify as Asian, as well as those who identify with multiple races. So it's just important for us to kind of keep tabs on frequency of use in these different demographics that might be a little more susceptible to use. In the last slide here, we're looking at past month use by sexual orientation. And we can see that for the habitual users, a little more likely to be prevalent among those that identify as gay and lesbian, as well as bisexual. So again, it's important that we kind of delve a little deeper in some of these indicators and keep tabs on some of these disparate populations. Because in general, those that identify as sexual minorities or those that are minorities in race and ethnicity tend to use drugs a little bit more than those who don't. So forgive me if you can hear a baby in the background. So I'm going to pass it over to my colleague, Megan, to talk about the impact of some of this use. Thanks.
Thanks, Tim. So consequences are defined as the social, economic, and health problems associated with use of substances such as marijuana. While it's important to understand the rate of substance use consumption, information on the effects of that use on individuals and communities can be derived from what we call consequence data. Examples of these include side effects or illnesses related to marijuana use, hospitalizations, property and personal crimes, driving accidents, and poisonings. And so here where available, data and findings are from the New England region, but in cases where we did not have data, US data are reported. So every state has drug driving laws dealing with alcohol impaired driving and drug impaired driving. However, unlike laws for drunk driving, those that address drug driving are nuanced difficult to enforce, and are prosecuted in varying ways substantially by state. And not every state has specific laws related to marijuana use. And so some are zero tolerance, so laws that make it illegal to drive with any measurable amount of substance of a specified drug in the body. And so these laws are best suited for illegal drugs, meaning if it's illegal to possess or use, then it's illegal to drive. And we also have per se laws, which make it illegal to drive with amounts of a specified drug in the body that exceeds certain limits. So 17 states have zero tolerance or non-zero per se laws for marijuana. There are 10 states that have zero tolerance for THC or metabolite, and 3 states who have zero tolerance for THC but do not mention any metabolites. 4 states have specific per se limits for THC, and then Colorado has permissible inference laws for THC as well. Additionally, in New England, the drug driving laws for marijuana vary greatly in that only Rhode Island has specific zero tolerance for driving under the influence of drugs, as well as for the zero tolerance for THC and its metabolites. Well, these laws have not been created for many of the other New England states. Additionally, the role of marijuana can play a role in car crashes and is often unclear as it can be detected in bodily fluids days or even weeks after use, and because people frequently combine it with alcohol or other drugs. So in a study that involved vehicle crashes with THC in their blood, there were 3 to 7 times more likely to be responsible for an incident than drivers who did not use any alcohol or drugs. And so this risk associated with marijuana in combination with alcohol appears to be greater than that for either drug by itself. There's also several other meta-analyses of multiple studies that have found risks of being involved in a car crash had significantly increased after marijuana use, and that risk doubled or more than doubled. However, there's another large case control study conducted by the National Highway Traffic Safety Administration that found no significant increased crash risk attributed to cannabis after controlling for a driver's age, gender, race, and presence of alcohol. So there are a lot of intervening variables that affect this measure because marijuana can stay in the blood for hours, days, weeks after use, and there's really not a standard measure for impairment. A lot of times these studies have been done by simulators, and so not with actual people driving. So it's hard to say if that's an accurate test. The alternative to measuring this is to ask people to report whether they were high or not at the time of the crash, which is also very subjective. So NIDA, CDC, and the Governor's Highway Safety Association have come to the conclusion that there's not enough data at this time to say whether marijuana makes a significant difference in the number of motor vehicle accidents. However, it's best to promote zero tolerance for using marijuana while driving. While emergency department visits for children have decreased substantially during the pandemic, the number and proportion of those that are cannabis involved have increased in 2020 and 2021. Overall, pediatric ED visits decreased 51% in 2022, 22% in 2021, and 23% during January 2022. But you can see that incidences related to marijuana are significantly increasing over those same time periods. Another consequence of increased cannabis and marijuana use is additional access for youth and young children. So according to the Northern New England Poison Control Center, in the graph on the left, we can see the number of calls regarding marijuana exposure for all ages has fluctuated quite a bit for Maine and New Hampshire, but remains stable for Vermont. And if we dig a little deeper into the data that we have for 2021, we can see that most of the calls in Maine and New Hampshire are for 0 to 5, whereas most of the calls for Vermont are in the age group of 6 to 12. So this could mean that the same prevention tactics for Maine and New Hampshire might not be appropriate for Vermont. And Vermont is doing something right in preventing accidental exposures for really young kids. And Maine and New Hampshire might want to investigate or coordinate. On a side note, out of all the data that we're showing you today, this is the only data that we had to make a special request for. So most other data sources are publicly available. However, you're also able to request data from the New England Poison Control. Treatment admissions by substance. So as you can see here, marijuana has the third most treatment admissions by substance, and this rate has remained stable from 2017 through 2019. Also, when we look at gender, race, and ethnicity, white males are more likely to report current use, but white males are least likely to report use, but are most likely to be admitted to treatment. And then if we look at arrest data, New Hampshire has the highest rates of arrests for marijuana possession, while Massachusetts has the least. And this information should really be taken in context, thinking through what we talked about earlier for the different recreational use, medical use, as well as decriminalization of possession. So we know that New Hampshire and Rhode Island have decriminalization, but have not yet legalized adult use. And then looking further, there's greater variability among the states when we look at the arrest data compared to possession. And you can see here as well, states with legalized adult use are decreasing, whereas those states that have yet to pass adult use are increasing. So we've covered a lot of data today. It's really important when you're developing programming and messaging to use as much data as you have available. It's also important to understand the messaging that is coming from the state and the industry, as well as where consumers are getting their information, so that the messaging created by prevention specialists can be tailored and have good counter messages. So what are the key takeaways today? So there's a lot of variation in state laws. We've seen variation in age of use from 18 in New Hampshire and Rhode Island to 21 in Connecticut, Maine, Massachusetts, and Vermont. We've also demonstrated the vast difference in how much each cannabis law allows. While nearly all New England states have legalized adult use to date, there are 2 states that have operational retail markets. But in recent interviews with state preventionists, adult use legalization and retail seem imminent at this point for all New England states in the next few years. Every state is set up differently to regulate licensing, certification, sales, and their data. We've shown you models from Connecticut, which are housed under the Department of Consumer Protection, to Rhode Island under the Department of Health, and Maine under the Department of Administrative and Financial Services. So models which incorporate representatives throughout the spectrum of prevention, health, our politicians, sellers, and users, as well as models that are solely reliant on government appointees. There's no one repository for this data. As you've seen, there's a lot of data sources that we've listed here and a lot of resources where you can find this data. Some states publish data more openly than others, and sometimes it's publicly available, although it can often be hard to find. It can be in meeting notes or long congressional reports. And even if you find the information, there's also a wide variety of terminology. So you may have a hard time finding what you're looking for if you're not searching for the right terms: marijuana, cannabis, commission, control board. And sometimes you have to get creative to find the data that you're looking for, such as accessing weed maps to see where some of the dispensaries might be in your local region. State agencies are also required to report on their revenues and usage of revenues, but the laws delegating the funds are very vague and often open to interpretation. So there's not a clear way to know how much of the revenue from cannabis is being funneled back into the public health and prevention markets. Prevention is fighting an uphill battle with marijuana tourism. There's a plethora of information and marketing out there, not only to promote use, but to drive use. And it's not firewalled by the same protections as alcohol and tobacco. So what's missing? As observed, some states have decidedly pretty limited committee representation for cannabis regulation. We know that in prevention that the best model is one that includes stakeholders from all populations who are impacted. So the plans to regulate, control, and prevent misuse are thoughtful, inclusive, practical, and comprehensive. Plans don't just look good on paper, but are backed by science and data and informed by the people in the field. Centralized location for data and set of metrics that each state could publish for transparency and trend analysis. As we've said today, the information that states publish and how it can be accessed varies widely. And so making the findings comparable and trending can be that much more difficult. So as we've discussed, there are also a distinct lack of clarity around how the cannabis revenue is used. So states should ideally provide clear language around how funds are used. Ideally, they should have transparent plans for supporting related public health and youth prevention education programs, and we should support and promote these policies. More research being publicly available and information on the impacts of cannabis legalization. So as shown, there's mixed methods about how cannabis use influences car crashes and fatality rates. Although we were able to locate some national data, there's still a lack of data that can be tied to cannabis use, unlike we have for alcohol. There's also some studies that have come out to say that legalization has decreased statewide due to opioid prescription dependence. And we really just need to have more information about what these impacts mean around legalization. The lack of data on cannabis use by demographic, for example, data on the use and employment settings would really be helpful for targeting prevention efforts in certain industries. The prevention field has some idea, but we need better information in order to identify our target populations and have the data to back it up. So how do we use what we have? Become more educated, not just around the evolving science behind the effects of cannabis, but also about the industry looks like in your state and what you're up against as a preventionist. This means looking out for trusted data sources, stay on top of consumption trends and effects, and also means being aware of the other sources that people might be using to get their information. We can see that arrests for possession are trending down as states decriminalize. Conversely, we can see some of the impacts of legalization on arrests for sale have increased in Rhode Island and New Hampshire over the last couple of years, but decreased in other New England states. Also staying informed of the legal changes, the state's cannabis and marijuana programming and related legislative measures, as cannabis legalization and regulation are rapidly evolving and changing. It's important to stay up to date. And looking for opportunities to target prevention work. So we know that for prevention funding is limited, and it doesn't look like that's going to become any more defined as some of those vague outlines for how the revenue is being spent. So prevention specialists should seek the biggest bang for their buck by targeting their efforts. And despite some of these decreases in perception of harm, all New England states have seen some trending decrease in the percent of students trying cannabis before the age of 13. However, we can also see that males are still more likely than females, and people who identify as anything outside of heterosexual, white, or Asian are almost also more likely to report initiation. Additionally, New England still has higher rates of use than other parts of the country. And in terms of how we use data to identify, we also know that white males and females have similar reports of past month use, and their frequency of use is different, where females are more likely to report using 1 to 5 times a month, and males are likely to use more habitually 21 or more times. And the same is true for differences by race and sexual orientation. And I'll turn it over to Kim to close us out.
Thanks, Megan, and thanks, Tim. So we know that youth prevention programming works, and know that there's a lot of information out there, and sometimes it's just not easy to find. Hopefully today's presentation gave you some more fuel for the fire. We have a lot of references at the end of this PowerPoint, and I know Kristen will be sending that out. And we have just a couple of minutes left. I didn't see a whole lot of questions in the chat, but I know that there was one about the YRBS having different gender options for the 2021 survey. Tamara, do you know if that's accurate? I haven't seen that survey yet.
Well, I know that there is a transgender option in the Maine Integrated Youth Health Survey, but I can't say for sure if there's also that option in the Wired Guest.
Mm-hmm.
And I know Corey's on the phone too. Corey Powell, the coordinator of MIAS, could help with that.
But we will be looking at that data as soon as it's published. Are there any other questions? No, we're almost at time here. Oh, Melanie said it doesn't look like it. How is data collected on adult use, 18 to 25-year-olds?
Well, that's the National Survey of Drug Use and Health, so it's a telephone-based survey.
And they actually we've linked to a couple of references for the national survey as well in here. Those are both SAMHSA surveys. So the SAMHSA has an interactive NISDA state estimate dashboard, and I think you can break it out by age groups as well.